Now we are moving on to the third section that also includes a benign variety, but it's little different. The benign tumors could be benign latent, such as fibrous dysplasia. They could be benign active, such as aneurysmal bone cyst, but they could also be benign aggressive variety. That is, they have some features of aggressiveness, that they're usually appearing a lytic lesion which is eating the bone. There may be cortical break, but they are overall of a benign variety, and that includes a giant cell tumor. In this section, we'll be going through the how to diagnose giant cell tumor, its staging and pathways, how to treat it, and what is the surgical management of giant cell tumors. So what is, as the name suggests, it's basically a benign but locally aggressive tumor of a bone composed of proliferation of mononuclear cells with scattered macrophages. Once these mononuclear cells coalesce, they usually form a large macrophage, which actually appears as giant cells with multiple nuclei. That is why it is termed as giant cell tumor. It's usually 5% of all the primary bone lesions. The most common age is usually between 20 to 45. Some books say 20 to 40. Some books say it's from 25 to 45. But on average, it's consensus between that. Usually it's the disease of second, third, and almost midway of the fourth decade. And usually it's in the adult. Occasionally seen in conjunction with the Paget's disease, but the important point is that it is an epiphyseal tumor, that it's along with this usually chondrosarcoma and chondroblastoma, it's most common in the epiphysis. Although it can sometimes, rarely, but yes, it can present in case of epiphysio-metaphyseal region. Usually arises in association with the focal dermal hypoplasia, which is part of a Gold syndrome, which is also a rare disease as well. But sometimes patients with Gold syndrome can have multiple GCTs in the body. It affects epiphysis, as I just told you, but rarely it is epiphysio-metaphyseal as well. Most commonly in the vertebral bodies, that is, in the case of the tumors, those affecting the spine, they are mainly divided in case those affecting the bodies and those affecting the posterior elements. Usually it's seen in the vertebral bodies of the sacrum with reduction in frequency as the spine is ascended. And usually it's highly rare to see a GCT in the thoracolumbar region and above. Mostly it's commonly found in the sacrum. In pelvis, the most commonly seen in the ilium, rarely affect the tubular bones of the hands. And if you see, this is how the radiology is, that this is the epiphyseal area. It's starting in the epiphyseal, and then probably this is where initially the physis was. Now as the physis is now closed, starting in the epiphysis and extending into the metaphyseal region, it's a lytic lesion. You can appreciate over here there is probably eroding the cartilage and the cortex as well. It appears as if it's a very aggressive lesion, that is lytic. It's eroding the cartilage and expanding in the medullary cavity. But although it's of a benign variety, that is why it is called as benign aggressive disease. Now, if you see it over here, this is a CT in which this GCT is actually involving the body of the spine usually, and these are the different views of the CT scan and X-rays. And this is probably the post-operative view, because once the whole curettage has been done, the whole tumor is actually taken out. Post-operatively, the spine stability may be affected. Therefore, some degree of fusion has to be done so that the spine remains stable, especially once this GCT is dissected from the body. Histologically, as I just told you, that usually it's the multiple large multinuclear giant cells which are actually seen on the histopathology, which is actually a diagnostic of GCT. This meaty, reddish, purplish tissue which is merged with soft tissue yellow areas. This is characterized by presence of large number of osteoclast-like giant cells among scattered around spindle-shaped mononuclear cells. So what actually happens is, in a normal body, osteoblast secretes a ligand called as rank ligand, which is actually rank stands for receptor activated nuclear factor K factor beta. Now this rank ligand is secreted by osteoblasts. There is a receptor called as rank receptor on osteoclasts. Once this ligand goes in and binds the rank receptors, the osteoclast gets activated. Now, this pathway is actually defective in case of GCT. What happens is that excess ligand is present. This go and bind with the receptor. This activates osteoclast and they start eating the bone out. As a result, there's a lytic lesion because this is lytic because there's hyperactivity of osteoclast, as over here we can see. So normally, normally it's osteoprotectin, which is actually, if you see it over here, osteoprotectin is actually binding the rank ligand. But if this is not there, then the rank receptor of the osteoclast goes and binds with the rank ligand, which activates the osteoclast. When these osteoclasts are activated, actually the bone resorption starts. Therefore, when we are doing the medical treatment of the GCT, this is the rank ligand rank receptor activation is actually what we are exactly inhibiting by use of denosumab. And I will be coming to that later on in the slides. So how do we stage the disease? Actually, this is staging is called as Campanacci staging system, which has actually 3 stages. This is completely intraosseous, means it's well contained inside it, it's not very aggressive. But if it's just it's spreading around and doing some kind of cortical erosion, then that becomes the stage 2, which demonstrates cortical erosion without destruction. But once the cortical break is seen, which that lesion actually expanding out of the cortex, this becomes Campanacci type 3, a stage 3 disease, which is characterized by cortical destruction with soft tissue component. As I just told you, the pharmacological therapy of GCT is actually involving the use of denosumab. And what does denosumab do? Is that it inhibits rank ligand rank receptor interactions. That rank ligand, which is actually, it binds with the rank ligand so that it does not allow the rank ligand to bind with the rank receptor, so that the activation of osteoclast does not occur, leading to therefore once the decreased osteoclastic activation is there, this would result in decreased lysis of the bone. That is actually the activity of the GCT is actually contained. It is to stop the osteolytic process and switch balance towards the bone formation rather than bone resorption. And it has a role in advanced stage 3 lesions or lesions in inoperable locations. Nowadays, the consensus is that you give these drugs at 0, 8, 15 and 28 days, and once after the 4 doses is been given, then subcutaneous 120 mg of the denosumab is given, then the surgery is performed, and then once monthly for 6 months it has to be continued post-operatively as well. Then surgical treatment, although it's a benign lesion, but it's a benign aggressive lesion, so we have to do some kind of surgery, and usually the surgery is extended curettage. That is for stage 1 and 2 lesion, extended intralesional curettage with a detailed debridement of the lesion wall. And usually recurrence depends on adjuvant treatment and time of the curettage. But nowadays, with the role of the combination of denosumab with extended curettage, there is very less chances of recurrence. For stage 3, once the cortical break is there and it is spread beyond the cortex, through is a thoracurettage with en bloc resection followed by radiotherapy, may be followed by a curettage, but usually, as now again with the advent of denosumab, rarely after extended curettage we may have to go for radiotherapy. But usually the protocol is for stage 1, 2 usually do not require radiotherapy. They only require denosumab, which is used as neoadjuvant chemo, then en bloc extended curettage. But sometimes in case of stage 3, maybe a radiotherapy is required. In this section, we have just gone through a benign aggressive disease called as GCT or giant cell tumor. The main summary is, the summary of this disease is actually that it's epiphyseal tumor. It's a benign aggressive, usually present between 20 to 40 or 20 to 45 years of age. There are 3 grades according to the Campanacci classification. There are stages of disease. Once it's intermedullary, then stage 2 it starts cortical erosion. In stage 3 it breaks the cortex and comes out. The treatment includes neoadjuvant chemo with the use of doxorubicin, with the use of denosumab. Sorry, now I'm mistakenly pronounced as doxorubicin. Then once the denosumab is being given till 28 days, then we go for extended curettage removal of the tumor and filling the cavity with bone graft or bone substitutes, and we may be in some cases radiotherapy in stage 3 may be required, but usually the post-operatively for 6 months once monthly dose of denosumab is also given. Thank you very much. Keep watching sqadia.com.